We are continuing with our national tele-education program, and today we have an eminent lecture in our eminent lecture series. We have a very eminent speaker, Professor Y.K.Chawla, who's a world-renowned hepatologist and gastroenterologist. He's former director of PGI and also the chief of hepatology services. He started liver transplantation in PGI, and Professor Chawla is a Padma awardee. And today he is going to be talking about non-alcoholic fatty liver disease. Professor Chawla, please.
Thank you, Dr. Meenu. It's a pleasure to be speaking to everyone today, those who are on the web and the YouTube. It's a very important topic that Dr. Meenu had given to me. We've had a pandemic of COVID. We also have a simultaneous pandemic which has been going on for a number of years, and that is non-alcoholic fatty liver disease. So let's briefly tell you what it is and take you through with measures how we can control it. Thank you, Professor Meenu, for inviting me for this very important topic. We've been passing through a pandemic of COVID, but we also should realize that there is another pandemic which has been going on in the country and all over the world for the last 10-15 years. And this is on non-alcoholic fatty liver disease, which would be my topic today. I would start my talk by giving you 4 representative cases. Very often, as clinicians, you would come across a case where the person is asymptomatic, he's got an ultrasound or a CT scan for some other reason, and he's told to have a fatty liver on ultrasound. He's a 35 years old male. When you do his liver functions, they are normal. When you do a fibroscan, which is something very, very important for patients with liver disease, his value is 4.7 kilopascals. Normally, the liver is less than 6 kilopascals, but when it goes on increasing up to 75, it gets features of cirrhosis liver once you cross 12. The causes of fatty liver could be because of alcohol, so that has to be ruled out totally. His hemoglobin A1C, diabetes is an important cause of fatty liver, so that was normal. Dyslipidemia also is another important cause, and that was normal. So this patient was kept under observation. Second representative case, again a 45 years old male who had a fatty liver on ultrasound. But when you did the liver functions, the SGOT, SGPT or AST, ALT was 2 to 3 times the upper limit of normal. This person was a little obese, and when you did his fibroscan, the value was 10 kilopascals, which indicates that he has some amount of advanced fibrosis, but he hasn't gone into a stage of cirrhosis, which you qualify only after the value becomes more than 12. The third case is a 50-year-old gentleman who way back about almost 20 years ago had shown us, 20 to 30 years ago, had shown us in the liver clinic, had evidence of raised transaminases and fatty liver. He was lost to follow up. He was extremely busy government official. He was a non-alcoholic, non-obese, but he was a diabetic for the last 15 years when he presented to us that time. And when he came to us in 2016, he had low platelets, fibroscan value was 60 kilopascals, endoscopy showed evidence of grade 2 varices, and this was a classic case of compensated cirrhosis. He didn't have any other symptoms, but he came back to us with raised transaminases, and that is how we picked him up with compensated cirrhosis. Fourth case is a 72-year-old female who was a diabetic for 7 years. Maybe she was diabetic even longer. hypertensive 10 years, non-obese, but she presented to us with ascites. Liver function showed raised enzymes. She had hypoalbuminemia. And when we did the fibroscan after her ascites settled, the value was 75 kilopascals. And endoscopy showed large high-risk varices. So you have this spectrum of non-alcoholic fatty liver disease. I didn't include very often now that we come across patients with hepatocellular carcinoma who've had NAFLD. So this is a very common chronic liver disease and it is rapidly increasing all over the world. It's an emerging cause of end-stage liver disease, liver cancer, and what used to be not a very important indication for liver transplantation about 20 years ago, when it was hepatitis B and hepatitis C, now has overtaken these viral-related cirrhotics and almost equal to alcoholic cirrhotics if you take from a large center where liver transplantation is done. Another thing to remember that it has a bidirectional association with metabolic syndrome. That means if somebody has diabetes, he's likely to have NAFLD, or if somebody has NAFLD, he's likely to develop diabetes over the years. And that is also true for hypertension, dyslipidemia. So bidirectional association. And now with COVID, it was realized that patients with non-alcoholic fatty liver disease had more deleterious effects on the liver and had worse outcome. Unfortunately, this disease has not been given that importance as it should have been given because of the rising cirrhotics. It affects the health economy to a very large extent. But fortunately, our country was the first one which took this up as a challenge. And now you have national strategies, and it has been included in the National Prevention of Cancer, Diabetes, and Cardiovascular Diseases and Stroke program, which is going on. So, how do you define NAFLD? Normally, hepatocytes on histology do not have any steatosis, but when more than 5% of hepatocytes on biopsy show steatosis in association with metabolic risk factors, in the absence of significant alcohol intake, by which I mean for a male 30 grams of alcohol per day, for a female more than 20 grams of alcohol per day, and which is equivalent to 30 ml of whiskey, 100 ml of wine, 240 ml of beer, which is about 10 grams. So you can multiply the factor for males and females. You have to exclude this before you make a diagnosis of non-alcoholic fatty liver disease. You also need to exclude the other common causes of a fatty liver disease and hepatitis B, hepatitis C, etc. There has been some discussion on changing the terminology of NAFLD to MAFLD, and this has happened over the last 2 years. Some groups say that the non-alcoholic fatty liver disease gives a wrong connotation to an individual who doesn't drink alcohol, and you give a terminology of non-alcoholic. So they say since it's associated with a lot of metabolic disorders, it should ideally be called metabolic associated fatty liver disease. But then the jury is out still, and the debate is going on between different groups of hepatologists. I personally feel that NAFLD should be continued, and it has been there in existence for the last 20 years. We also need to realize that NAFLD could be precipitated by drugs like acetaminophen, methotrexate, halothane, tamoxifen, rosiglitazone, and I'm sure there are many more, including the complementary medicines. So, what is the spectrum of this disease? It's basically a continuum of the disease. The very first stage is what is termed as non-alcoholic fatty liver, which is also simple steatosis. You do a liver biopsy in these patients, there is fat, more than 5% of the hepatocytes are affected. Unfortunately, ultrasound and CT scan do not detect these cases except when you do a liver biopsy. They detect only when the 20 to 30% of hepatocytes are loaded with fat. And in this group of patients, the elastography is normal. You have a very good imaging now, what is termed as magnetic resonance spectroscopy, which detects even 3% of steatosis and has a very high degree of sensitivity and specificity. But then this is a research tool and everyone cannot afford it, is very expensive. Persons after simple steatosis go into a stage of non-alcoholic steatohepatitis. As the name suggests, there is some amount of inflammation, there is some amount of ballooning, and with or without fibrosis. Although the amount of steatosis within the liver has no correlation with the amount of fibrosis. But then when you biopsy about 100 of these simple steatosis patients, 10 to 20% of them would have non-alcoholic steatohepatitis. And this is the group of patients who have a value of transient elastography of more than 8 kilopascals. You need a liver biopsy to diagnose this. There is no way that you can diagnose it otherwise, except transient elastography. Initially, it was thought that raised transaminases would give you a diagnosis of NASH, but in 11 to 30% of cases, the ALT is normal. So you may not pick up these cases, but it's very important to treat this group of patients because ultimately they would land up into cirrhosis and liver cancer. And this is all because of repeated and protracted necroinflammation. Then you have the third stage, what is termed as NASH-related cirrhosis, and you by and large call them as cryptogenic cirrhosis. Almost about 10 to 12 years ago, we from our department here had shown that this group of patients had higher BMI, higher waist circumference, and more often had type 2 diabetes mellitus. The picture is much clearer now, and a study from a big transplant center found that of the cryptogenic cirrhotics that they transplanted, almost 63% of them had features of non-alcoholic fatty liver disease. So by and large, cryptogenic cirrhosis, when you have ruled out all other causes of cirrhosis, cryptogenic cirrhosis is possibly due to a fatty liver disease. And lastly, NASH-related HCC is also known to be an important contributing cause for HCCs. This again we had shown some time back that those who had cryptogenic HCC had a higher BMI and had evidence of diabetes more often. We need to realize that cirrhosis is usually a precursor for HCC, except in patients of NASH and some patients of hepatitis C. So the patient may not go through the stage of cirrhosis. He may directly go into HCC in about small percentage of cases. And whenever these patients have evidence of diabetes, obesity, hepatitis B and hepatitis C as comorbidities, there is a 10-fold rise in the risk of HCC. So, NASH-related cirrhosis and HCC is the most rapid growing cause of liver transplantation, and hence there is an urgent need to tackle the impending burden of these two end-stage liver disease. Now, what is the disease burden in India? Different studies have happened all over the country, and it ranges from 9 to 35% of the population. But this is only on ultrasound, which picks up about 20 to 30% of hepatocytes laden with fat. The prevalence is likely to be more. For patients who have to be given a liver transplantation and those who have evidence, a liver biopsy is usually done in the donors, and they found that 1 to 4% of these patients had evidence of NASH. So, amongst the healthy population, about 1 to 4% without significant evidence of fatty liver disease would have NASH. So NASH in the general population is about 1.5 to 6.5%. And when you look at the total population of the country or all over the world, it eclipses the burden of hepatitis B, hepatitis C, which are important causes of cirrhosis and HCC. So hepatitis B is about 3% in our country, hepatitis C is 1%, the two combined together is 4%, but NASH, which is a precursor of cirrhosis, is seen in 66.5%. Our own study from PGI by Dr. Ajit Useja in blood donors showed that about 55% of them had steatosis on ultrasound. Any diabetic would have about 63% chance of having a fatty liver disease, and of these 10 to 20% would have advanced fibrosis, by which I mean they would have gone into a stage of compensated cirrhosis. So it's very important to pick these patients of diabetes and find out whether they have liver disease or not. Obesity, about 80% of them would have fatty liver disease and 10% would have advanced fibrosis. Now, we all know that childhood obesity is also increasing, and this statistics in 2 to 5 years age group found that obesity in 2011 was 8.4% in the United States. It had gone up to 13.9 or 14% in 2015 and would be increasing even further. But when statistics amongst the pediatric population were done for fatty liver disease, 7.6% had fatty liver disease, and in obese children, 35% had evidence of fatty liver disease. There is also a group of patients who are not obese, who don't have diabetes, but still, when you do an ultrasound, they have a fatty liver disease, and who have a normal BMI. These are the patients who are termed as lean NAFLD, and this is a specific group of patients. Although they behave almost same as the usual classical type of non-alcoholic fatty liver disease, their long-term prognosis is almost the same as those who have associated metabolic liver disease. But this is a new entity which is being studied further, and it's possibly attributed to dysfunctional adipose tissue, some amount of genetic mutation, epigenetic changes, and different gut microbiota. So NAFLD is a very important problem, and especially if one is to take these up for liver transplantation, you need to do very good risk stratification, because post-transplant these patients are more prone to develop cardiovascular events, develop metabolic complications, and this is further amplified by the immunosuppressant therapy which is given to them. They are also more prone to develop post-liver transplant complications and de novo malignancy. So, what is the natural history of these patients? It's an extremely slowly progressive disease, in contrast to hepatitis B, which grows rapidly, which damages the liver rapidly. These patients are usually asymptomatic. They may present with vague abdominal pain and picked up on ultrasound or a CT scan, and patients coming to you with raised transaminases, when you do the ultrasound, you may pick these patients up. But something which is very interesting and I want to draw your attention is a meta-analysis in almost 4,500 patients with non-alcoholic fatty liver disease, which was done many years ago, found that when you follow these patients by paired biopsy, patients with NASH over a period of 7 years have an increased stage of fibrosis as compared to simple steatosis, which takes about 14 years. So NASH is a progressive disease. Simple steatosis may be progressive, but it is extremely slow. You also need to realize that once fibrosis sets in into the liver without the stage of cirrhosis, then it is an important cause of cardiovascular mortality. These patients would not die of liver disease, but cardiovascular events like stroke, myocardial infarction. But once they go into the stage of cirrhosis, what is termed as F4 stage, they die of liver related mortality, and the relative risk is about 12.78. Another thing that you should realize, and something which is very important, that when you treat these patients, the fatty liver doesn't go off very fast. It takes almost 5 years to disappear on ultrasound, just in about 20% of individuals, and more often in females, those who have low insulin resistance, and those who are thin. So, in clinical practice, patients keep on coming in telling you that your enzymes are normal and you feel absolutely fine with treatment. But on ultrasound, the findings of a fatty liver are still persistent. You tell them that it takes a very long time, and also in a small group of patients where you can see changes of the fatty liver. So, as I said, fatty liver not only affects the liver, but because of the metabolic component to it, it affects almost all organs of the body. And the most important organ that it affects is the cardiovascular system, where there is deposition of perivascular adipose tissue, epicardial adipose tissue, and there is coronary artery calcification. The chances of atherosclerosis are much high in these patients, and that leads to increased mortality. Because of low grade inflammation and cytokines that these patients have, they have a longer QTC duration and they are more prone to cardiac arrhythmias like atrial fibrillation and ventricular arrhythmias. They may also have structural heart disease like aortic valve sclerosis and mitral annulus calcification. Meta-analysis of 11 studies, including more than 8,000 patients of NAFLD and type 2 diabetes mellitus, had shown that the cardiovascular risk increases by twofold. Atherosclerosis also increases significantly, and our own study from PGI showed that the carotid intima media thickness and endothelial dysfunction occurs in these patients, which is also responsible for the vascular changes that happen. And as I said previously, hypertension either predates and diabetes predates NAFLD or postdates NAFLD. So there's a bidirectional association between the two. The other diseases that can happen simultaneously would be chronic kidney disease, colorectal adenomas, malignancies, obstructive sleep apnea, depression, osteoporosis, gallstone disease, and sarcopenia. So, looking at an advanced stage of non-alcoholic fatty liver disease, you need to look at these extrahepatic manifestations also. So, what is the pathogenesis of a fatty liver disease? These are multiple hits. We all know that if we over feed ourselves and have less physical activity, the adipose depots they increase. There is increased ectopic fat. This is one consequence. Second is these patients have insulin resistance, and this insulin resistance promotes macrophage infiltration into the adipose tissue, releases pro-inflammatory cytokines, leads to lipolysis, leads to formation of lipotoxic lipids, which causes apoptosis of the hepatocytes and stimulates the hepatic stellate cells. There is also an element of genetics, especially PNPLA3, which is a group of genes which now have shown that it plays a very important role in fibrosis of not only fatty liver disease but all alcoholic liver disease and hepatitis B and C. And lastly, gut microbiota has been found to have a very major role in a lot of diseases that we all face, and so also it has shown that it contributes to fatty liver disease. There is a crosstalk between the gut and the liver because of the fecal microbiota, and these particular bacteria are more in patients with NAFLD. So, giving you this background, how do you manage these patients? The most important point is you have to assess the disease severity, and disease severity is assessed not by the aminotransferases levels or by the bilirubin or INR, but by the severity of fibrosis because it has a strong correlation with mortality, either cardiovascular related mortality or liver related mortality. As I said earlier, liver enzymes correlate very poorly with histology. Liver biopsy is the gold standard for picking up patients with NASH and fibrosis, but it is risky, not acceptable by every individual. It is costly, has an element of sampling bias. And this interesting study in 2015 showed that when you did biopsies, paired biopsies in the same individual, over a period of 3 years, even simple steatosis may progress onto cirrhosis and increased fibrosis. So, since liver biopsy is not a commonly accepted procedure, you have non-invasive tests because it prevents unnecessary liver biopsy and it can be of extreme help to the primary caregiver for these patients. And some very important non-invasive tests for liver diseases and especially non-alcoholic fatty liver disease is FIB4, which you have to take into account age, AST, platelet, and ALT. And this is all on a calculator. Less than 1.3, patient doesn't have any amount of fibrosis, and more than 3.25 has advanced fibrosis. So it has a very high negative predictive value. Then you have a NAFLD fibrosis score. You can adopt any of these, whatever is simple for you, which includes age, BMI, IGF, AST, ALT, platelets, and albumin, and values of less than 0.12, no fibrosis, more than 0.65 is fibrosis. Something which is more widely accepted is APRI. You just have to have the AST and the platelet ratio, and it gives you an idea of whether the patient has cirrhosis or not. The UK guidelines for non-alcoholic fatty liver disease has a very complicated score, what is termed as ELF score. And for that, you have to measure hyaluronic acid, P3NP, which is procollagen, and TIMP, metalloproteinases, and which is not practically possible. But then they say that if it is above a certain value, you should refer these patients to a hepatologist. But something which has changed the practice of hepatology recently is fibroscan. As I said, less than 6, normal liver stiffness. If it becomes more than 8, means there is some amount of fibrosis. And any value more than 12 is cirrhosis. And as the value increases, the complications also set in, like ascites, upper GI bleed. This particular study from Bovino, which deals with portal hypertension, says that any fibroscan value of more than 20 kilopascals and platelet counts less than 1.5 lakhs indicates that the person has high risk varices. Another score, FAST score, not widely accepted, but that is another way of picking up whether the patient has cirrhosis or no cirrhosis. But I need to emphasize here that ultrasound, CT, and MRI are not able to identify the subtle changes in fibrosis, which is important for treating these patients. They would only pick up once the patient has gone into a stage of frank cirrhosis. So, how do you treat these patients? Unfortunately, the FDA has not approved any pharmacological therapy till now. They are all off-label drugs that we are using. Many of them are in the pipeline. But something which is most important that we all need to follow in such cases is lifestyle intervention, where you have a control on the calorie balance, which takes care of the lipid and glucose hemostasis, in turn decreases the oxidative stress and the inflammatory signals. And it takes care of the stellate cell, which is important for fibrosis. So you have to correct comorbidities like obesity, diabetes, hypertriglyceridemia, and if there is evidence of insulin resistance. And you again need to realize that patients with PNP LA3 of a specific phenotype, GG, responds better to lifestyle interventions. One should aim for a gradual weight loss of 1 kilogram per week. This would decrease the cardiovascular risk and steatosis and inflammation. If one is able to achieve a weight loss of 3 to 5%, it would improve only the fat but stabilize the fibrosis. But if you're able to achieve a weight loss of 7 to 10% from your basal weight, then the fibrosis also tends to get regressed. For lean NAFLD who are not obese, even a 3% weight loss is good enough. But then lifestyle interventions have their own problems. You're not able to maintain weight loss for very long, and just about 15% of them have a maintenance of weight loss. Not all would adhere to diet and exercise, but one should avoid cigarette smoking and beverages, especially the sweetened beverages, which have simple sugar and fructose, because it is a substrate for development of de novo lipogenesis. Community-based studies, randomized controlled trials have shown that the lifestyle intervention improves the metabolic and cardiovascular risk factors and bring about a decrease in fibrosis as measured by transient elastography, and magnetic resonance spectroscopy has shown a significant decrease in the fat. So it's important that lifestyle interventions need to be done in these patients. One should ideally advocate a hypocaloric diet, which is less than 500 to 1000 of the basal diet that the individual takes. But then you have different diets like Mediterranean diet and ketogenic diets, which all have shown to be of benefit to these patients of NAFLD. Something which is coming up now is the role of intermittent fasting, which could be alternate day fasting or 5:2 fasting. That means for 5 days you eat whatever you want except for carbs and fats, and 2 days you remain fasting. That improves NASH. And 14 to 16 hours of fasting. That means you have your dinner at 7 o'clock in the evening and have your breakfast at 9 would give you adequate amount for the liver to decrease the amount of fat and improve the NAFLD, as has been shown in the studies. We all need to realize that in the night we are not burning our calories, and whatever we eat in dinner is likely to be utilized for developing fat in the hepatocytes. Interestingly, during Ramadan, there have been studies where people fast, and that shows an improvement in lipid profiles and liver enzymes and NAFLD. Coffee is something which is advocated for all patients with liver disease, and it is an excellent way of decreasing NAFLD. Increased fiber also has been shown to improve steatosis. Turmeric and chicory seeds also have of benefit, and some liver supplements like L-carnitine and silymarin or milk thistle have also been shown to improve steatosis, insulin resistance, and fibrosis in a small group of patients. Exercise is also important as a part of lifestyle intervention. These patients are usually sedentary; they are not interested in exercise, and but they should be advised brisk walking, jogging, which improves the cardiovascular profile. And this exercise should be between 150 to 200 minutes per week, should include both aerobic and anaerobic or resistance exercises. And exercises have shown that it alters the gut microbiota, which has an important role to play in improving the NAFLD. But in a small group of patients, firstly, lifestyle interventions are difficult to adopt, may not be adopted by everyone, and a significant proportion of these patients do not respond to lifestyle interventions also. So then ultimately we land up with a pharmacological therapy. But as I said, FDA hasn't approved any, and we offer them treatment as a part of the clinical trial and try to correct the comorbidities as much as possible. So, what is an ideal drug? That which improves NASH and fibrosis, decreases body weight, improves lipid profile, glycemic control, and cardiometabolic risk factors. And during these trials, you try to bring down the ALT levels and improve the scoring of the fatty liver disease by more than 2. An interesting fact in most of these trials, which amount to almost 10,000 trials which have gone over the last 10 years or so, the placebos have been responding in 25%. And that means the lifestyle interventions happen in about 25%. And whatever medicines you give, uh, a very slight increase in the responses happen. A maximum of about 60% has been reported by some of the drugs. So there is an element of resistance, and now the hepatologists are thinking that using a combination of drugs would possibly bring about the response better. Ursodeoxycholic acid, omega-3 fatty acids, metformin, statins have not been shown to be of any histological benefit. Vitamin E is something very popular, but since it is an antioxidant, anti-apoptotic, there have been studies which have shown that it resolves the non-alcoholic fatty liver disease or steatohepatitis, but it doesn't affect the hepatic fibrosis. So this could be a modality of treating with 800 international units every day, and you could go on treating these patients for a period of 2 to 3 years. But the concern is that it may lead to hemorrhagic stroke or prostatic cancer. The other drug which is commonly used is the insulin sensitizers, and this happens only in patients with diabetes. And the most important one are the PPR agonists. These are expressed in the adipose tissue and they improve the insulin sensitivity, at the same time improve the hepatic fatty acid oxidation and anti-inflammatory effect. Fibrates, which are known to have an effect over triglycerides, have been disappointing. But the one which has shown promise is pioglitazone, which is used for diabetes mellitus, and meta-analysis have shown that it decreases steatosis, NASH resolution, but the concern is the weight gain which happens in these patients, and they are more prone to have cancer of the urinary bladder. These patients are also prone to have fractures. A drug which has started in India and is being used extensively in trials is PPAR alpha gamma agonist, saroglitazone. This is not available in the West, and if it is given in patients with diabetes and dyslipidemia with evidence of NASH, it has shown excellent results. It improves transaminases, improves the fibrosis as well as the lipids, decreases the cardiovascular risk. The other group which has been tried in these patients are the GLP receptor agonists, and which are incretin mimetics. It increases the insulin sensitivity, decreases glucagon, delays gastric emptying, and improves satiety. And two drugs which have shown good results are the liraglutide, which is given every day to patients with diabetes mellitus. It decreases the body weight, controls the diabetes, and also improves features of steatosis and NASH. But concern is it leads to cardiovascular deaths, more often have MI, they may develop stroke, and hence has not become very popular. But the other drug, the newer molecule semaglutide of the same group, which is available either as an oral formulation or subcutaneous, has shown resolution in about 40% or more number of patients, but has not shown any effect on fibrosis. The advantage is they decrease the body weight. The other group is DPP4 inhibitors, and they are used in diabetics. And omarigliptin has been shown that it improves NASH and improves fibrosis FIB4 score. Something which is very popular now and is gaining acceptability is SGLT2 inhibitors, and this is in the form of gliflozins, which very often the diabetologists use. It not only decreases the weight but also improves the liver fat content, enzymes, and fibrosis, and these are the examples of EMPA, DAPA, and canagliflozin, which has been shown on spectroscopy that it significantly decreases the fat content. Something which has become very popular over the last 1 year is the FXR agonist, and the drug is obeticholic acid, which not only improves the amount of fibrosis but also improves the amount of fat within the liver. It increases the triglyceride clearance from the liver, but the side effect of it is pruritus, and it increases the cholesterol levels. So that is a cause of concern, but this is a very good drug, and there are some trials which are being done in patients with compensated cirrhosis whether it can decrease the fibrosis there. Cilofexor is a new molecule, again a FXR agonist, and firsocostat, as I said, combination has been tried and has been shown to be a little more promising. Another interesting group of drugs is thyroid hormone receptor beta agonist. It is said that there is hypothyroidism in the hepatocytes in patients with NASH. And when you give this drug, resmetirom, it has been shown to decrease liver fat, improves resolution of NASH and fibrosis. So this is a very exciting drug which we hope would come up in the market very soon. Fibroblast growth factor is another drug which has been shown to improve fibrosis. So, we have to look at drugs which improve fibrosis at the same time also tackle steatohepatitis. And there are a very few group of drugs which improve the fibrosis. And there are many, many new molecules which I would not like to elaborate here. They're all in clinical trial mode, and the results would be available as more number of patients are recruited. Patients who are obese may improve their liver by doing a bariatric surgery, but this is indicated if someone's BMI is more than 40 or if he has comorbidities and BMI of more than 35. It is very effective way of losing weight. About 10 to 25% of weight is lost, and it is found that NASH and fibrosis tends to get resolved. But the problem is, if the patient has established cirrhosis, then bariatric surgery has its own problems. And very recently, metabolic endoscopy has come into practice, where you do the duodenal mucosal resurfacing. You burn the duodenal mucosa, which is the site where the glucose and lipid metabolism happens. So this has been tried. Endoscopic sleeve gastroplasty, which was done earlier on by surgery, now has been done by endoscopy, and there are ongoing trials on its use in patients with NASH. So friends, I've taken you through the whole spectrum of fatty liver disease and the drugs and how you manage these patients. But we need to realize that the prevalence is increasing, relative young aging population, and there have been a large number of studies where they have shown that the NASH related cirrhosis has increased. And you also need to realize that since these patients are asymptomatic, it is a silent epidemic. So it is an emerging public health problem globally, and it also affects the heart and other organs of the body. Taking this account, the government of India had a meeting of Niti Aayog way back in March 2020, and there were a lot of discussions between hepatologists and Niti Aayog. And finally, in the month of March 2021, they included NAFLD in the program, the national program of the prevention and care of cancer, diabetes, and cardiovascular diseases. So what they said is at the primary care level, the ASHA worker could easily pick up patients more than 30 years with a BMI of more than 23, waist circumference more than 90 for males and 80 centimeters for females, any family history of diabetes, hypertension, coronary artery disease, and liver disease, and excluding patients with alcohol, hepatitis B and C, would then be taken up in the community health center with a liver function test, FIB4, and complete blood count. Here I need to mention that platelets are a very important component of telling you the amount of fibrosis. Patients with cirrhosis would have values of platelets less than 1.5. So as a hepatologist, we try to look at the hemoglobin and platelets because that gives us an indication of the amount of fibrosis. And once you pick up these patients with fibrosis, you refer these patients to a tertiary care center or a district hospital, which would have transient elastography. And a lot of training and capacity building is happening for the recognition of NAFLD. The problem is, the challenges are, it is still, we have to cover a lot of education and the recognition by health carers and community care Action has to be done by diabetologists and those who deal with obesity. It has to be a multi-pronged public health response. And we need to improve the obesogenic environment, which is very rampant with McDonald's, Domino's, and others. So, friends, in conclusion, I would say that we are going through an pandemic of non-alcoholic fatty liver disease. We need to identify these patients, and those who have evidence of advanced fibrosis should be treated with lifestyle interventions. We should have NAFLD care team, and there should be a close talk between hepatologists, internists, cardiologists, endocrinologists, dietitians, and nurse practitioners. We should train the health professionals who can pick up these cases, bring about increased awareness of NAFLD and its consequences. Non-invasive blood tests for liver fibrosis should be widely popularized. FIB4 and APRI are something very, very simple. And maybe in the future with telemedicine, smartphone applications, telehealth monitoring of dietary intake and exercise, and motivational protocols could be brought about by the digital health. So thank you very much for your attention. I would be happy to answer any questions if there are, and I hope you spread this message to your friends also. Thank you.
Thank you very much, sir, for such an illuminating talk. I think it is an eye opener that NAFLD is it is a pandemic, and the disease burden is increasing as you showed year wise. So, what kind of screening do you suggest, or what should be the protocol for screening for this disease, say amongst obese or diabetics and normal population? Should we be for, because it's just like it looks like hypertension and diabetes, that and probably liver plays like a master of orchestra of all these diseases,
That's right.
non-communicable diseases like diabetes, hypertension, cardiovascular diseases,
Right.
dyslipidemia. So I
So
think we should be
I
concentrating.
think we should start with picking up patients who have diabetes or pre-diabetes stage, and this could be from the diabetes clinic. Patients who have hypertension, who are obese, if we can pick them up from the endocrinologists. Those who have cardiovascular disease, the cardiologists need to come in. And if we pick up these cases, find out about the liver disease, we could manage them at an early stage. But when we talk of the general population, that is going to be fairly difficult. You would be able to pick up only those cases in whom you do the investigations of ultrasound, or for some reason you do their liver functions and hemogram. But if awareness is more, then people would come forward to getting their ultrasounds and liver functions more often, starting them at an early age. It could happen in the schools, it could start from the college, and since childhood obesity is also something very important, so the education of the public should start from the schools itself.
Yeah, and prevention also would be much better if we start from childhood.
Yes,
And
prevention is absolutely important. You know, studies have shown that the health economy, because of NAFLD, is goes haywire. They have very good studies from US where they say that because of the fatty liver disease, which ultimately leads to cirrhosis, transplantation, HCC, the amount of money that an individual or the government pushes for these types of diseases, and these are all preventable diseases.
right.
So they should be picked up at an early stage. But education is absolutely important.
Sir, there is a question on YouTube. Should diabetics go through regular screening for NAFLD? I think that is what
Yes,
the
yes,
question
yes,
was.
it's absolutely important.
And Dr. Bhupendra Kumar, it was a very informative and useful talk. What is the usual dose of L-carnitine and pioglitazone for NAFLD?
Yes, L-carnitine, I would not be able to tell you, but we've been using it in clinical practice. You know, it all started when L-carnitine was used in patients with carnitine deficiency, who had evidence in children and small children. And giving L-carnitine improved the fatty liver in these cases. So, and in my own practice, when these patients do not respond to the routine drugs that we give, L-carnitine is excellent. In NAFLD patients, the value of the serum level of L-carnitine is less. Pioglitazone is the same as what a diabetologist would advise the dose. I'm not very fond of this drug because it tends to increase the weight and it has some amount of side effects. So, in my own clinical practice, vitamin E if the person is a non-diabetic, or saroglitazone if the patient is mildly diabetic and has evidence of dyslipidemia. Otherwise, my third choice is L-carnitine.
So there are a lot of compliments for you, and one question is, how does coffee protect the liver?
Coffee has a lot of antioxidants.
Right. Okay.
So, when you take 3 cups of coffee, that also without milk, the black coffee, there are adequate studies to show that these patients, you can prevent chronic hepatitis, prevent cirrhosis liver. But then it's difficult to have 3 cups of coffee every day, at least for Indians, and that also without milk. But there are adequate studies to prove that. In fact, we are recommending it for patients with hepatitis B and C. Any liver patient that comes to us, we advocate the use of coffee.
Okay. So we had a kind of tragic experience in our department here. There was a person who had NFLD, and once he got COVID, he deteriorated very fast, and actually we lost him. Have you come across such instances during your practice during the pandemic time?
See, I didn't practice with COVID, but certainly there is enough literature which says that because NAFLD is a pro-inflammatory state, and COVID also is a pro-inflammatory state, where these pro-inflammatory cytokines, the levels go up, the mortality is high in these patients, and that possibly explains why the patient.
A number of patients did report that the illness was prolonged in them, probably one of the causes of long COVID.
That's right. That's right.
If they had some kind of.
So it's a combination of pro-inflammatory cytokines.
Persistence of raised enzymes and
that's
probably
right.
thrombocytopenia.
That's right. That's right.
Okay. Madhumita Prem Kumar, she wants to know safety of herbal medicines in NAFLD.
Well, that's a very debatable question. I can't really say the safety. You must have read in the newspapers and others that Giloy tinospora has been found to have effect on the liver disease. So I would not be able to answer this. I personally would not advocate the use of herbal medicines
without testing them. Probably.
Without testing them.
Because Shok Singhal says, Swami Ramdev says diabetic can be controlled through some yoga exercises to tone up pancreas. Is it possible?
Yes. I think although there are no studies as such, we've been wanting to do this study in PGI for a very long time of yoga and the control of non-alcoholic fatty liver disease. But if it has an effect on the control of diabetes, the NAFLD also would improve. So, although there are no studies to prove that, but of directly yoga and NAFLD, but since yoga has affected the diabetic status through indirectly, it would improve the liver also. So I think we have done with all the questions which appear there. So would you like to give a last minute message to general public about? Yes, I think this is a very important disease, which condition which would very often you would encounter in your clinical practice. And the message should go that it is not a benign condition. Anyone coming with a fatty liver disease may go on to cirrhosis and liver cancer. And certainly a combination of hepatitis B, C, alcohol in this group of patients increases the chances of severe liver disease, increases the chances of fibrosis, development of cirrhosis and HCC. So not only should you take care of the diet that you take, at the same time, exercise is very important. And unfortunately, we don't have ideal drugs for treating these patients. Whatever we have, lifestyle intervention is the best as of now. So kindly spread this message to all your friends. Fatty liver disease is a major problem, and hopefully in the next few years we'll have a good drug for that.
Yeah. So many drugs actually which are kind of on the trial and
Yes,
everything.
yes, yes.
But I think not all of them are available in India right now. Or
No, some
most
of them are available, but they have not been approved as such.
Right.
They are all off
Off-label.
off-label drugs.
Thank you, sir. Thank you for coming here and delivering
Thank you,
such a
thank
wonderful
you.
talk. I'm
It's
sure
been a
everybody has
pleasure.
benefited.
It's been a pleasure
Thank you
coming
so
here.
much, sir.
Thank you.
Like
Thank
to
you
have
very
you
much.
again for some other topics.
Sure. Thank you.
Thank you very
Thank
much, sir.
you. Okay.